Hello, everyone. Before we dive into today's conversation, I have some exciting updates to share about my book, The Unexpected Way That a Stroke Became the Best Thing That Happened, which is now approaching 400 copies sold and is receiving excellent reviews from readers who find it both inspiring and practical for navigating post stroke growth. One listener, Sandra, recently commented on our YouTube channel, "I brought your book from Amazon. It's great to read, lots of information to think about. My arm is slowly recovering. It's frustrating. I tune into your podcasts and I feel better. Thank you. Hope you get 100 million listeners soon." Wow, wouldn't that be something? If you haven't picked up your copy yet, now is a great time to do so. Also, remember to visit recoveryafterstroke.com/learn for a range of courses and resources created by a stroke survivor for stroke survivors, helpful tools to guide you through every step of your recovery journey. On today's episode, which is a must listen for anyone questioning the limits of stroke recovery, we're speaking with Dr. Matthew J. Ashley, a board certified neurologist and a neuro rehabilitation specialist who holds a law degree. Dr. Ashley brings a unique blend of clinical expertise, personal experience, and legal insight to his work, making him a powerful advocate for stroke survivors. His journey began with a personal connection to brain injury and has evolved into a mission to redefine what recovery means, particularly challenging the conventional idea of a recovery plateau. In our conversation, we explore how Dr. Ashley's background in neurology, neurorehabilitation, and law shapes his holistic approach to rehabilitation, why the notion of hitting a recovery plateau can be more myth than reality, and what that means for your ongoing recovery, the challenges of navigating a fragmented healthcare system and the importance of self-advocacy, and the role of integrated care, including therapies like nutrition and lifestyle changes in driving continuous improvement. Be ready for an empowering conversation that challenges traditional recovery narratives and offers practical insights to help you push beyond perceived limits. Let's get started. Dr. Matthew Ashley, welcome to the podcast.
Yeah, thanks, Bill. Thanks for having me.
Absolute pleasure. Tell me a little bit about your background.
Yeah, well, it depends on how much you'd like. I'm a neurologist by training, and then did subspecialty training in neurorehabilitation. But my journey with dealing with people with brain injuries starts much earlier. And there's a personal and a family connection to that, and really kind of grew up in the environment in a literal sense of people who were rehabilitating from predominantly traumatic brain injury, but other types of brain injury as well.
Were you quite young when your family member went through something like that?
Yeah, so my father's brother, so my uncle, unfortunately, before I was born, had a aneurysmal rupture, and was quite disabled from that for quite a period of time, and that was kind of the um, inciting factor in some ways for the development of the organization that I still work with, which is a family business where we run a rehabilitation facility for people with any kind of acquired brain injury, and that includes stroke. So his journey was his journey, and I was very young, so I only know bits and pieces of it from sort of hearing it growing up, and I have some sort of vague memories of him. And of course, it's difficult to discern what's really my memory versus what I've seen in photographs or videos. But that was kind of the personal side to that. And I grew up in a family who was both working with him initially and then subsequently working in the brain injury rehabilitation space. So that was always just sort of part of my world. I would, after school, go and do my homework at the clinical facility and, you know, kind of grew up around that in a very real sense. So it was always sort of part of my life in the background. Um, And then later on, as I got older, and ended up going into medicine as a career, I tried to approach that with an open mind and think that perhaps some other field would grab me and I would gravitate towards that. And there were certainly other things that I enjoyed and liked, but in the end, I really still liked the work that I kind of grew up seeing. And so I did the neurology training and with an eye towards ultimately ending up in the rehab world.
Were your parents physicians as well?
No, my father and mother were both speech pathologists, actually, by background, but really, saw a need in, my uncle and others that were their kind of initial patients for something that was more comprehensive than what at least existed at the time, and that was kind of the birth of our organization.
I think back to my upbringing, and school homework was done at home. And I didn't know anybody who had a brain injury at all. And it kind of shaped me in a way of being unaware of people's plight, some of the challenges that other people face. And I could say, you know, very comfortably that I was ignorant of what it's like living with a brain injury until the age of 37 when I had my own experience. Your upbringing and your interaction with people in that space would have been completely different from anybody else who you went to school with, hung around with. This might be a hypothetical question, but do you think it changed you, it shaped you differently than it would have perhaps if you were just a regular kid going home to a kitchen table to do your homework?
Yeah, I think it's a hard question to answer, and don't get me wrong, sometimes I was at home doing my homework.
Yeah.
Uh, but being around it, I think it's impossible for not to shape some of your worldview. Seeing people who are struggling with something like you've mentioned that most people can't really conceive of, or if they do, it's in a peripheral sense. It does give you a different lens with which to view the world, and I honestly feel very lucky to have seen that early in my life, and to really it helps shape a perspective of maybe some gratefulness for things that otherwise uh, you know can be difficult to be grateful for. And I don't want to act like I'm some sort of Zen master who's always living in that space. I'm a human being and I experience frustrations and, you know, all those things like everyone else. But I do think it helped to shape the narrative and the arc of my life and help me really, again, value that population of people that I had grown up around and witnessing their plights and their struggles and their successes and all of that, and to really be able to grasp what is possible for people who are going through that in a way that, as I went through my training later on, really helped me become a better professional as well,
Mm,
because I had seen things that really went against kind of maybe the traditional thought process for how people's outcomes would be or what was possible, if you will.
yeah. I think, 5% more gratitude growing up is a massive thing above the majority of kids, going to school and high school. You're probably a step ahead there just because of that.
Well, I don't want to. I have my version of what I was like. I'm sure it's very far from the truth. I certainly had my other moments as a child too, of
Yeah.
being entitled and feeling like, these minor frustrations we experience are a big deal. I don't want to make light of that. I think that's the human experience, but it does help. It does help, and especially as we get a little more gray hair and start to realize other things about life. Like I said, I'm very thankful that I grew up in that environment. I think it has helped me, and it helps me as a parent and as a a physician to just have that perspective.
Let's take a quick pause here before we dive back into Dr. Matthew Ashley's insightful discussion about breaking through the recovery plateau and optimizing stroke recovery. I wanted to remind you about some important resources. Firstly, my book, The Unexpected Way That Stroke Became the Best Thing That Happened. You can get it on Amazon or at recoveryafterstroke.com/book. It's already inspiring hundreds of stroke survivors. Also visit recoveryafterstroke.com/learn for narrated video lessons and other resources crafted specifically for stroke survivors and caregivers. Now let's get back to Dr. Ashley and learn more about his unique background in neurology, neurorehabilitation, and law, and how it's reshaping the conversation around stroke recovery. So, what was your first qualification after high school? Which path did you head down?
Yeah, so I went to University of California, San Diego for college, and there I eventually ended up landing on a bachelor's of science degree in cognitive science with a specialization in neuroscience. So again, sort of that that thread of all of this has been present in my life in some way, shape, or form, more or less throughout. Um, and that kind of degree is sort of this mishmash of biology, neurobiology, psychology, and throw in a little bit of computer science in there as I was studying that. And that of course has come more to the forefront now. That's not really where I ended up landing. So my computer science part of me died after I graduated college, but it was helpful background and sort of useful. And then from there, I ended up doing my graduate work in Illinois at Southern Illinois University, and I did a combined law and medical degree there, and that was a 6-year program, and finished up that in I guess 2009. Then did a neurology residency and eventual fellowship at UCLA, and that was kind of my arc.
Wow. Does law and medicine go together, or is that something that you do thinking you might go down one path or another path? How come they get done together?
Yeah, well, my young person version of that answer is different than perhaps what it is now. When I first started that, I really had an eye towards the advocacy piece that applies to, people with brain injuries of any kind. Unfortunately, part of the nature of the injury is often an ability to communicate well, which is a crucial part of self-advocacy and advocacy for, a group of people. And then the other part that, I don't know how if we want to get into all this, but the insight component of brain injury is one that is particularly problematic. That many times people who have had these kinds of neurological difficulties aren't necessarily so aware of the problems that they're facing, and that poses its own whole host of difficulties. And from an effectiveness in advocating for yourself, you can see you don't have to get too far to know that it's going to be detrimental and problematic if you don't really think you have a problem, that you're not going to really be a good self-advocate. So the early on when I did that, that was kind of a major driving force. Looking back on it now and in retrospect, I think, having an understanding of the law broadly, what the kind that you get from going to law school and not really, practicing in a specific area, which is where I ended up landing. It's just helpful. It sort of informs a lot, ranging from the things I set out to do on the advocacy parts to legislative things, and as kind of mundane as contracting. So uh, I don't regret a minute of it, but
Uh, Honestly, it sounds like a good thing to have in the background, especially when you're coming from your perspective. The reason being is, one of the struggles that people face dealing with the medical system, the universal struggles. In America, it's slightly different because of the way that you guys access medical help through insurance, or if people are not insured, other means. And here in Australia, the medical system is uh, pretty pretty good. You get free medical for every citizen, and then people can also opt to have private insurance to cover their medical costs. And usually, private insurance gets you, um, to skip the queue and a choice of hospital, a choice of doctor, those kind of things. I didn't go through a private system, went through the public system when I was unwell. And after one of my, after the second bleed that I had in my brain, which was in March 2012, my cognitive impairment was pretty great. And my wife was the person doing all the communicating between me and the doctors and trying to suss out where I was, what type of help I needed, etc. And of course, she's not a nurse, she's not a doctor, and she's never dealt with anyone that's had a neurological condition before. So a lot of the things that I needed were not presented for me, or they weren't diagnosed. And most of that was in the cognitive deficits, the inability to remember a person who came to visit me, start a sentence, finish a sentence, uh, have a conversation with anybody. So it was quite a challenge for me to navigate any of my recovery at that time. I had no idea other than kind of be this passive survivor, and then I wasn't even hoping for the best because my brain wasn't even switched on. It was completely switched off. It was offline. So I don't know what I was doing other than sitting through a process and hoping for some kind of a positive outcome. So I love that fact that already you're thinking, you particularly, and maybe your organization, as a result of the work that you've done and the training that you've had, you're already thinking about our patients come to us are still going to be requiring advocacy amongst other things. And that it seems like you've made it part of your philosophy or part of your role to also ensure that your patients are being treated appropriately, medically and ethically, but also are being guided by your organization. How do you navigate that with your families that come through and your patients or your clients?
Yeah, yeah. That's a really big question, Bill. I mean, for starters, just coming back to you and your situation, big congratulations on everything you've accomplished in terms of not only your own recovery, but putting together something that you've done here. And again, I'm still becoming a little bit familiar with your work, but I think it's really important, and it's great to have the platform that you've developed for others to be able to shorten their learning curve for exactly what you're describing. Everyone who's going through this, the vast majority of those people are coming to it like you were. They everything was fine, and then one day it wasn't, and that happened to them. It happened to their family, and all of a sudden, this whole thing is thrust upon them, and they're trying to manage it, and it's you know, to put it bluntly, it's a nightmare. So you have, um, and again, I don't know the intricacies of how things work in Australia, but I'm intimately familiar, for better or worse, with how they work here. And there are a lot of great things that work in our system, and there are unfortunately some vagaries. And so what we try to do is shepherd our patients and families as much as possible through that process. And I would love to be able to say that I'm able to help every person who comes our way, and unfortunately that's not the case. But the ones that we do, we really try to maximize what we can do for them. In terms of how we go about that, we really try to take a whole patient approach, and that's kind of a buzzword, but I think for us it really does apply. We have a comprehensive care setting where we have everything ranging from physician level care, nursing level care, all of the various therapeutic disciplines. So that includes physical therapy, occupational therapy. There's probably different terms. Some people, say physio, and there are other terms, but in here it's physical therapy, occupational therapy, speech language pathology. We actually break out the cognitive component and what you're discussing into two buckets. And we approach that from a speech language pathology perspective for certain aspects of that, including dysphagia and swallowing, but also cognitive components of that. And then we also use people who come to us from an educational background, and a kind of a school-centric background to also augment that, because we feel, like you alluded to, that the cognitive part of the recovery is really where it's at. Because yes, it's very important for people to recover their ability to ambulate, for their ability to use their fine manual dexterity and their visual system and all of the other things. But at the end of it, what really, really ends up limiting people from having a high quality of life and independence and the things that for most of us we consider very, very important is that cognitive component. And so we focus a lot there. And then buried within that as well is we have an embedded counseling and case management presence in our organization who the case manager is kind of like the architect of the entire experience, pulling everything together and shaping it into what it should be. And the counselor is there not just for patients and people who are experiencing the insults, but also their family members, because we know, and I'm sure you've experienced, I don't want to speak for you, but having, you alluded to it with your wife, having someone there advocating on your behalf, seeing things from a different lens than maybe you're seeing it yourself is so critical to success.
Mhm. It's one of the biggest challenges. I know stroke survivors who don't have the support that I had will they will do exactly that. They'll try and navigate the stroke world both as their own advocate, but then also as a patient. So as a patient, it's nearly impossible to do as a patient who's experienced a stroke. But then as somebody who's not an advocate by nature, or is has never been in the position to advocate for somebody else or themselves, now they have to navigate a system where they're advocating for themselves, a system they don't know, and at the same time, this recovering from a stroke. It's just a minefield. I mean, it's almost an impossible task. And that's the thing about uh, the medical system in Australia. It's quite good, but I'll go and visit my neurologist, and then I'll get some kind of a report or some kind of an understanding of what happened to me, and that's cool. And then after my surgery, for example, when I had to regain the use of my left side and learn how to walk again and use my left arm, uh, after the hospital stay, the initial month hospital stay, where all the energy was focused on the physical rehabilitation, there was no work done on the cognitive rehabilitation. Uh, there was no assessment to see what other services I required. It was the obvious things that were supported. Okay, Bill, wake up from surgery. Let's go for a walk to the toilet for the first time after surgery. Oh, Bill can't actually walk. Oh, okay, we need rehabilitation. We need to get his leg working again. And really, that was kind of the extent of the process. So after I'm not sure as well in the whole experience where the neurologist came in to the conversation and where they stepped out. So then after that, I get sent to outpatient rehab because my 1 month stay in inpatient rehab ended. And that's done about a from my house, it's about a 30 to 40 minute tram ride and then walk to the particular facility. I wasn't driving, so I had to walk there in my fragile, just learnt how to walk state when my wife wasn't around when she was working. And then these guys had the task of rehabilitating me further, getting some of those fine motor skills developed further. But again, uh, there wasn't the, it seemed to be fragmented. The whole system was fragmented. You know, you saw a specialist over here at that place, and then you saw somebody to help you get your walking back at this place, and then it was a little bit all over the place. So if it was very difficult to get um, efficient care and treatment to make the best use of my time and the best use of the time of the people supporting me in getting better.
Yeah. And I think that your experience is, unfortunately, is a very common one. I think that it's very unusual that someone has a smooth experience that coordinates all of the various parties that really need to be at the table in order to maximize the the potential, for recovery and to do that in a way that's consistent and coordinated and where each party is talking to each other and sharing notes on what they're understanding and finding, and then sharing that with you and with others in your life. So, our system over here is also highly fragmented, and that's at different levels of care. So, your first encounter with the healthcare system here, I would imagine, is very similar. You're going to have EMS, and then you're going to have emergency department evaluation, which, for stroke is going to mean, um, you know, CT most likely right out of the gates. Many instances followed by MRI, not every instance. In a situation like what you're describing with bleeding, sort of then you're off to the neurosurgical track and okay, do we need neurosurgical intervention? Do we need to decompress? Do we need to evacuate hematoma? Do we need to clip or coil aneurysms? So there's a whole host of possibilities there. And then if you're in the ischemic stroke bucket, then you're onto the neurointerventional, hopefully, track if you're in time. And that means, can we go in and extract clot and reperfuse area of brain. And that's all sort of this, what I would call hyperacute, management. That's happening within, hours to the first day. And then that person's then going through hopefully a neuro ICU. In some settings, there may not be a neuro ICU. It might be a general ICU. And that period of time can last anywhere from a day to weeks, months of time, depending upon this particulars of the scenario. And that in that setting, things are relatively coordinated. And as you suggested, the degree of focus on recovery and rehabilitation is low. It's more focused on let's stabilize, let's preserve, let's keep people, frankly, alive. And, then there is a shift, when people get to a more stable kind of situation and they're in the general hospital sort of floors, then you can really start to dig a little bit more. But again, even then, the cognitive aspect of things usually is not being addressed. It's usually more focused, even from a speech perspective, it's more focused on things like swallowing and can you eat safely? Can you meet your nutritional needs by mouth, or do we need to do something else to help support you? So those are, again, ideally people are paying attention to some of the other aspects as well, but it's sort of buried in the background. And then from there, at least here, the next step for, I'd say, most stroke patients is going to be to go to hospital-based rehabilitation. And I don't know what that looks like in Australia, but that could be a different floor in the same building. It could be a completely separate facility. And that's the first time, at least generally speaking here, where if patients are stable enough, people might start really honing in on some of those cognitive processes and starting to address them. Um, and then from there, it gets even more fragmented. It could be that that person goes home from there and then they're dealing with piecemeal, as you suggested. You're seeing your physio in 1 hour on one day, and you're seeing your occupational therapist 1 hour on a completely separate day in a different location. They don't talk to one another. They maybe read each other's notes, but maybe not. The neurologist, who, with I have tremendous respect for my specialty, but most of them by that point, they're doing medical management of your risk factors and comorbidities, but they're not intimately involved in the rehab process. So that's where things get really split. And at least here for us, the mission that our organization tries to fulfill is filling that void and getting people from that hospital-based environment into a much more real-world environment where they're in a living environment that looks like home. It's not a hospital bed in a hospital room. They're getting up in the morning, they're getting themselves ready, they're going to therapy, during the day, and it's sort of reestablishing that kind of normal rhythm of life where you have a morning and you have a routine and you get up and you go and you do your work is doing your recovery work. And it's with folks who all have experience in working with brain injury, and then also are talking to one another and collaborating and saying, hey, I've identified this issue, this problem that we need to try to address, and then everyone's working together to solve that. So, yeah, I think the description you gave is kind of the reason that our organization exists, is to try to remedy some of those fragmented delivery models that
Mm.
exist.
I love the idea of that. So, one of the big frustrations that I get is people tell me that they reached out to their neurologist and they don't get the right kind of answer or support or help or whatever. But I feel like people are going to neurologists for the wrong reason. Can you give me a bit of understanding of why I would go to a neurologist, what type of um, information they'll provide, what kind of support they'll provide, so that we can debunk the I went to my neurologist and they didn't give me anything. Like, I feel like stroke survivors are clinging to neurologists as the be all and end all of, if I go there, that they'll be able to look at my scan, tell me what's wrong with me, tell me how to fix it, put me through the whole system. But I think that we're misunderstanding what neurologists do.
I would agree. And I think, there are different types of neurologists and different subspecialists. So it's a little difficult to put everyone into one basket, but I would say that even within the field of stroke neurologists, who there is a subspecialty, for stroke, um, most of that is focused on either the acute interventional side, or in the clinical setting, and meaning like ambulatory clinic, the kind you walk into. They're going to be focused on what was the cause of the stroke. So causative factors. And that can vary depending on the type of stroke and what you're really up against. So, looking at, is there something that was an underlying cause of stroke that we have not yet identified that we could potentially manage and treat and prevent subsequent stroke? So with hemorrhagic stroke, those are things like I've mentioned where you have vascular anomalies. Maybe you have certain conditions that are affiliated with aging, where people are prone to having bleeding into their brain. And I don't want to get too technical. We can, Bill, if you want.
We don't have
I don't
to.
want to overwhelm the audience with jargon, but um, there are conditions that can predispose you to having bleeding into your brain. The most common of which is some kind of vascular abnormality, but there are others. And then there are conditions that similarly will predispose people to having ischemic strokes, a stroke where blood flow to the brain is interrupted. And that can range from the things that we all think about with heart disease. So high blood pressure, high cholesterol, diabetes, smoking history, et cetera, to genetic conditions where people are predisposed to forming clots, autoimmune conditions where people are predisposed to forming clots or having inflammation in their vascular wall, the blood vessel wall. So a lot of the emphasis with neurologists is on looking at, okay, why did someone have this event? And then depending upon the nature of the event and where the damage to brain or potential damage to brain occurred, we can give some idea of what are the problems that people are going to be like to be experiencing. We can also do an in-person assessment, you know, to identify some of those deficits. But what neurologists are not particularly well suited to do, at least in our treatment paradigm here in the United States, is to actually really dig in to the nitty-gritty and identify how do we help this person recover from this in a moment to moment, hour to hour, day to day, week to week basis. That's not generally speaking. I'm kind of an exception in a way because I'm part of something much broader than me in our organization, but I'm even in our setting, I'm not the one on the ground doing that work. That's being done, by all of the great people in our organization that I mentioned. So our therapists, of the educational people, the counselors, the case managers, they're the ones who are really unpacking that just little by little and layer by layer and helping people identify problems and then address them. So long-winded way to answer maybe, but I hopefully that is at least a start.
I think what I understand is that neurologists are diagnostic. They will diagnose something, whereas, and when people go to them for solutions to cognitive deficits, my arm's not working properly, physical deficits, etc., well, then they're not really equipped to handle that intervention or that approach or whatever it is that needs to happen for that person. But they're diagnostic. They can tell you if the stroke that you experienced was caused by a one of the conditions you mentioned, and in the or if it was caused by something other than something that you're predisposed to in the brain. For example, a PFO. If somebody has a PFO, it's really not a neurological thing. It is a heart condition, and then that person would be sent off down that path. And I feel like that's a really classic example, actually. Like, somebody has a PFO, a clot is formed, it gets stuck somewhere in the brain, it causes a stroke, and then often stroke survivors are going to neurologists with those types of conditions. I've had a stroke, not realizing that it's kind of, for lack of a better way of explaining it, not realizing that it doesn't matter specifically that they had a stroke because their underlying cause is a heart condition. And therefore, the neurologist diagnostic and time, I would say, involved in that whole acute phase is going to be basically just stating the obvious. There was a clot, it came from the heart. It isn't a brain problem. It isn't a vascular problem in the brain. It is just a stroke that was had. And I feel like that is probably the extent of it. Does that
I
encapsulate it
think
at all?
there's a bit more. So for starters, you're absolutely right. Cardiac conditions can be the underlying cause of stroke, and that is well known. And the more common one that even than PFO is atrial fibrillation.
Yeah.
So that's part of the diagnostic evaluations for ischemic stroke is to look for those things and identify them and then manage them. So in the management of them, it depends upon what you find. So that is the diagnostic piece of neurology in stroke is definitely prominent, especially at the beginning. As time goes on, depending upon what's identified, there is there is an ongoing role for someone from either neurology or physical medicine and rehab background for managing things as they arise. So, as people go on, and again, not to get technical, but there are many, many things that can happen down the line that emerge because we know that even though stroke happens in one very short, finite period of time, it's really it's an evolving process across the recovery. And it takes a very, very, very long time to navigate all of that. So, people can develop, just to use one example, they can develop spasticity in their arm. I don't know if that's something that you experienced, and that is something that needs to be managed in various ways. You can manage it with medication, by mouth. You can manage it with peripheral interventions with injections with example with Botox, or you can use there are other techniques that can be used to help with that. And then spasticity is a moving target. It's not like it starts and stops. It has gradation. And so you've got to sort of have a practitioner who's going to work with you across time in identifying what's the appropriate intervention, and then where things settle 18 months down the line is likely to be very different than 6 months in, which is likely to be very different than 6 days in.
Mhm.
So there is a role in an ongoing way for physician level involvement, whether it's neurology or physical medicine and rehab, in managing things of that kind of ilk. But there, there's not a day-to-day kind of role for most physician providers in rehabilitation. That needs to be done sort of elsewhere. And I think if I was someone dealing with brain injury of any kind, but definitely with stroke, I would hope to learn that initially, early on, so that you're not expecting that your neurologist provider is going to do all that for you, because that, again, with respect to my discipline, we will fail.
I think that's the point I'm trying to make is that there isn't the neurologist deals with my brain, therefore the neurologist should be able to handle all aspects of my brain. And it's it's just through a lack of awareness, a lack of knowing, a lack of having been in the system before, a lack of having experience with stroke. You cling to somebody to help you in this space, and of course, you go to the person that what's the word, that you probably touched base first, and then you hope that that person's going to handle everything because you don't want to go to 1,000 different places. And that's kind of what I think does that. And I think also choosing the neurologist with the wrong speciality could be an issue too. Initially, without knowing, you find a neurologist. Oh yeah, I've heard he's good. He's near me. I'll go and check that person out. I'll tell him what my problem is. You get there, and it's like, mm, there's not much more I can do for you. You've had a stroke, etc. And then sometimes you might just come across the wrong person who says, you'll need to be referred to a different area. Sometimes stroke survivors, patients also don't know to say, where else, if I can't, if you're not the right person, who else should I go and see? That's kind of what I think is missing, and what I try to bring awareness to is like curiosity, more questions, more searching, be comfortable not finding the right person at the beginning, um, and just be on the quest to forever find the right person for you is my approach.
I think you hit the nail on the head. That's it. We have, and I think it gets even more confusing, honestly, than it should be,
Mm-hmm.
because if you have a stroke, right, your intuition would be to go see a neurologist who has experience in stroke,
Yes.
and that's great, and that you should. But then there's a point at which it needs to be transitioned to someone who has more of an emphasis on recovery and rehabilitation.
Yeah.
And that is not intuitive. So I think, again, reaching your audience with that message is really helpful.
Yeah.
So
One of the big challenges that I, as a podcaster on this in my little neck of the world, in my little nook in the world, um, yeah, I tried to be the bridge between stroke survivors, medical professionals, other stroke survivors. I just try to be a bridge. There's not much more that I can do, which is a pretty good thing. And one of the big challenges that I face is hearing stroke survivors, no matter where they are in the world, saying, insurance said I've hit a plateau. Um, because, and it doesn't matter their age. And in Australia, it's a similar thing in that hospitals will make the decision that a patient has reached a plateau, whether it's the public or the private system. And one of the other areas that they do that in is where I feel people are discriminated against is um, older age. So in our family, my brother's father-in-law had a stroke a number of years ago. He's almost 80 years old now. And when he was assessed and discharged from the hospital, I think it was really abrupt. Now, his stroke was about 8 or 9 years after my whole situation and my journey of navigating the hospital system, etc. And I feel like they kicked him out way, way sooner than they should have, um, making generalizations like that's about all he can expect to recover and so on. And then handballed him home to his wife, who's similar age, and who are caring uh, uh, who are caring for a child who was born with cerebral palsy. So that's really close to my heart, and I'm thinking, they did a terrible thing uh, discharging this gentleman so early. Now, when I interview stroke survivors, I often hear, they cut off my rehab because they said I'd reached the plateau, and I feel like, and when I have a conversation around this, I feel like the word "you've reached a plateau" is just a term that insurance companies and hospitals use to remove somebody from the system, so that that's either costing them too much money, so that they can bring somebody else in, um, A, to create space, but also B, that they're more likely to get an outcome on. Give me a bit of an insight into what you feel like that plateau is all about and why it even gets used in rehabilitation of people with neurological conditions.
Yeah, it's funny, but you use that word plateau, and um, I don't want to say that's a dirty word, but to me, it's a word that I share your frustration with. We have a saying at our organization that patients don't plateau, people don't plateau. I'm not done getting better in my life, so I don't know why I would think that other people should be. Now, that said, I understand the background of where the term comes from, and it is important to be able to communicate as best we are able expectations and prognostic implications to people and their families. So, we know that recovery trajectories tend to be steeper earlier on than they are as time goes by. Um, that said, there are certain things that I think get frequently mentioned to patients when they're early on in the course of their illness, and I think these things are said in well-intentioned ways, but they are not um, necessarily always interpreted or heard or even said in the way that's most beneficial. So,
I'll interrupt you for a sec. I'll tell you what those things are. You're probably never going to walk again, or you're probably never going to go to work again, or you should think about retiring, or and so on and so forth. Stroke survivors whinge about it still to this day, every opportunity they get because there still happens so much. And um, you're probably never going to walk again. It seems to be a really uh, disheartening way to have somebody leave a hospital. So you've rehabilitated them, you've made them healthy enough to live, and instead of now encouraging them to take the next step, you're going, we got you kind of there, but you're probably not going to walk again. Uh, Out you go. Like it just seems so it's so counterintuitive to say that I'm putting all this time, money, resource, training, 100 years of medical knowledge into keeping you alive and stopping you from having another stroke, but you're probably never going to walk again.
Well, I would go further, Bill, and say not only is that not helpful,
Mm,
it's also probably wrong.
mm,
Um, because at least as it pertains to people who've had a stroke, because the numbers will show that most people who've had a stroke, particularly of the where you're having that level of dialogue and conversation, most of those folks will walk again, in the given the right set of circumstances. So that's a big no-no. I mean, I don't know why yeah, that's not something. The one I think is more commonly said is putting a timeline on certain things.
mm. Yeah,
If you get to the 3 month interval or the 6 month interval or the 12-month interval, that gives you a good idea of where things will be. And while on some level, that statement, there may be some degree of accuracy to some components of it, I don't think it's helpful. And I think that it artificially places a barrier where none necessarily exists. And because people do continue to improve, not just through 12 months or 18 months or 24 months, but I mean, for a very long period of time. And so I think that's discouraging, and I don't know that it's useful. I think it comes from a place that's well intentioned, where often people are asking, "What do we expect?" And rather than having a more nuanced and more difficult discussion that is hard, which is to say, I can't really tell you an answer to that. I can tell you some experience with it, but that doesn't apply to you because you're one person and your loved one is one person, and they're going to experience their recovery trajectory as they experience it. Um, it, it, I think people default to these sort of more simple answers. And this relates back to your plateau comment, because I think that idea of a plateau um, is part of the problem, if you will. And that isn't to say that at some point pragmatic discussions about levels of care, whether people stay in ICU environments, whether people stay in hospital environments, whether they stay in rehabilitation hospital environments, whether they stay in facilities like ours, those discussions are important and they need to be had, but they don't have to be had in such a way that places a limit um, unnecessarily on an individual's recovery, prognosis, quality of life, etc. Am I drawing a meaningful distinction, or is it?
absolutely. I completely understand. And I don't think a doctor sets out to discourage. I don't think a doctor sets out to um, possibly create a negative uh, an, a negative association afterwards. It's just that there's not a lot of thought put into what you said. How am I going to have the exit conversation with my patient, or how am I going to open the first conversation? I just and I also get it. Like I'm not having a go at um, physicians specifically. more about the words that they use and their inability. And part of it is also their ignorance of, I don't know what it's like to have a stroke. So you might see people having strokes and you're dealing with them all the time, but you've never had one. And it's really cool. I never actually want you to have one. Um, so that part of it, it's multifaceted. I suppose what I'm trying to do is allay the concerns of the listeners who have had that comment made to them, and then take it to heart, and then prove their doctors right instead of wrong. I would much rather say, you know what, just if you're not that kind of person, if you don't do things just to prove people wrong, maybe you should start now. This should be the time. Let's just prove them wrong. Because wouldn't it be great if you went back for a follow-up appointment 12 months later and said, you were wrong, doc, like, and it's not because you want to have a doctor who's wrong. It's just because you want to, break down this kind of barrier that doctors have around, can I be honest with this patient? Can I be honest by saying, I don't know, and I don't have all the answers for you? And that's all. That's all that is. I know that nobody becomes a doctor to then dishearten somebody on the way out and say to them, oh, I've done all this stuff to help you out, and yeah, forget about it. You're done. I know that doesn't happen.
No, I think those kinds of comments again, they're coming from a place of attempting to provide something.
Yeah.
I think they end up, as you mentioned, being net negative for the moment and the experience. And I think, you know, as people, but definitely as physicians and medical providers, we have to be humble and recognize when we don't know things. And knowing someone's recovery trajectory from stroke, I mean, I'm getting a little bit grayer by the day and I still don't know.
Yeah.
So I think, you have to balance the need that people have for getting information and some kind of conceptualization and an idea of what to expect with the downside of placing limits on people. And also, Bill, I think it's important for me to acknowledge, my bias is we probably share the same bias in the sense that, um, you know, I see the people who make it to my level of care and the people who we get the opportunity to provide care for. And um, in many ways, sometimes those are the outliers. Those are the people who do, as you suggest, kind of buck the odds or
Mm.
and I would echo your sentiment. Give yourself the chance as a person who's experienced this to maximize what you can accomplish in the wake of it. I think, don't accept those limits on yourself, at least in terms of those kinds of broad statements. And as you get further out, there is a balance to, accepting the new normal,
Mm.
while still striving for more,
Mm.
okay? And giving up. Those are different things. And I think the negative aspect of what we're talking about is the component that might lead someone to giving up on something that otherwise might be attainable.
Yeah.
And again, we're talking about stroke and recovery from stroke. There are other situations, when you talk about spinal cord injuries or things of that nature, where a statement like, you know, walking is probably going to be really challenging to attain is more accurate. So again, we're doctors are people and they have to learn things. And sometimes, these are things that people have to learn along the way by being humbled by an experience like what you're saying of someone coming in and defying what they expected. But I think, I don't know how many physicians are listening to this, but hopefully maybe this is a way they can they can learn it. I think, physicians learn from patients, the smart ones, all the time. So yeah.
Yeah, that's it. I think I'm telling stroke survivors, patients to be the outlier, aim for being the outlier, and see where it falls. You might go for being uh, you know, the rare person who does the opposite of what their doctor said they would achieve. And you won't know that unless you go for it. You've got to go for it, and you have to make sure that you put all your time, effort, and energy into that. And take a comment from a doctor as something that um, may have been uh, inappropriately applied to your situation because that doctor had a hard day and thought they were talking to a different patient. Just put it down to a mistake.
Yeah, and ultimately, like I said earlier, I'm not done trying to make myself better,
Mm.
right? In general, so I don't think anyone should be, right? We should always be striving for more, and yeah, I love that approach. I think it's great. I think it's uh, you know, people who are dealing with recovering from stroke are going through so much, and that day-to-day ups and downs can be so difficult on their own, let alone if you have this sort of broad, negative limit that someone has put over your head.
Mm.
So yeah, chalk it up to a bad day, chalk it up to a bad doctor, chalk it, I don't know, a bad, but forget about it and move forward, and try to get better.
Yeah. Your organization, Center for Neuroskills, I'm on the website right now looking at the programs that it offers. You've got therapies for, you've got aquatic therapy, which I absolutely loved when I went through rehab. It made me feel safe. It made me feel like I can't fall down. Uh, it was just, it was amazing to be in a swimming pool and doing my walking rehab in there. You've got cognitive therapy, counseling, which is just fabulous. I would have loved to be able to access counseling while I was in rehab. I did access it outside of rehab. So I was going to outpatient counseling. Probably at the beginning, I was going maybe, uh, I'd say once a month or twice a month, depending on how much mental challenge my new mortality had created in my life. Um, you've got education therapy, you've got neurobehavior therapy. I mean, you guys do so much occupational therapy, physical therapy, speech and language therapy, vestibular therapy, vision therapy. You've got it all. I love it. I wanted to ask you specifically about uh, nutrition. It's a big emerging intervention that people can use to make a massive difference in the way that they experience their body after stroke, particularly uh, fatigue. Experiencing fatigue after stroke seemed to decrease when I changed my habit of eating a really high processed, large amounts of carbohydrate diet to a lot less of that, and then uh, increasing my protein levels and my vegetables, that type of thing. Now, maybe you can't answer this question, and that's okay. But is there any work done in your organization that addresses people's nutrition?
I mean, we certainly try. So the issue of nutrition is big, and I think what you just described sounds like a great move overall in terms of just your general health,
Mm,
right? I mean, most of us, you know, fortunately, we exist in a time in human history where we're not just fighting for calories, right? We're able to choose the kinds of calories we get and where they come from, and you know, we can choose them for different reasons. We can choose them because we want to enjoy them right then, or we can choose them for you know, better outcomes in terms of whatever that is. Weight, if we have specific concerns, if you know we're diabetic or we have cholesterol issues or hypertension and whatnot. So I mean, it sounds like the general thing that you did was a smart move. Just any doctor would paint that with a broad brush as a good choice. In terms of the effects specifically that it's going to have on neurological recovery, I mean, I think in general, the things that we do that promote good overall health are going, whether that's, you know, controlling intake of, um, you know, carbohydrates with high glycemic index, and et cetera, you know, or um, controlling just our overall caloric intake, control getting adequate protein, getting adequate, you know, fiber from those red and green vegetables. Those are all things that help, you know, promote general health. And general cardiovascular health is brain health. I mean, our brain is the same. We're perfused in our brain. You know, we get blood flow from the same blood vessels we do in our heart and everywhere else. And there's probably more to this story that has yet to be fleshed out, right? Um, you know, I'm not as familiar with some of this in terms of stroke specifically, and more so in terms of traumatic brain injury. But we know that, you know, when there's an insult to the brain from trauma, different factors relating to call it homeostasis, right? Inflammatory markers, cytokines, different patterns of activation of different cells, glial cells in our brains. They are perturbed, and that persists for long periods of time. So, you know, I don't pretend to be an expert on nutrition or on that other buzzier field that it's kind of the microbiome, right? And all of these things. I think anyone who purports to tell you they have all those answers, you should probably run the other direction because they're probably not being honest with you. But it's definitely something where in the coming years, decades, et cetera, we're going to learn a lot more.
Mm.
And we're going to know better how all of this is interacting with each other. But what I would say is that if you noticed that difference, Bill, run with it, right? Stick with it. And I think there's more to come on the front of, you know, what are the effects of some of the various medical interventions that we have that are controlling, you know, our appetite, our caloric intake, you know, and having impact on satiety and other things. And,
Mm.
you know, it gets even more complicated when you start incorporating those things. And then when we have insults to the brain from trauma, but also from others, you can impact the hormone systems of the body because we don't think of our brain as controlling all of these things, but it does. It controls things as simple as our heart rate and our respiratory rate and our metabolic rate. So there's a lot to unpack there. I don't pretend to have all those answers, but I will say I think what I advise I give to patients if they're inquiring about their nutrition is the things you just suggested. Get lean protein sources, you know, get your red and green vegetables that have nutrients and fiber, you know, in them. Those are the primary components that, at least in the Western diets, tend to be areas of relative deficiency, right? And then avoid those
Yeah. Cans of Coke.
glycemic index carbohydrates. Yeah. So yeah.
Yeah. Look, it may be a little bit an unfair question. I didn't ask it to put you on the spot or catch you out or anything like that, but it's a common thing that people overlook. You know, I'll interview stroke survivors to tell me that they're eating healthier, and they'll pick up a can of soda while we're in the interview. I don't know, maybe it's my job to say, you're probably doing the wrong thing there, and maybe I have permission or not to do that during an interview. I don't know, but it's interesting that there's still not enough conversation, I think, happening around the impact of nutrition. There's a lot of new research coming out, and there's a lot of people reporting on. When I say a lot of people in the medical fields are reporting on, the benefits to the brain by changing the diet, and it's exactly what you said. You see the same diets being thrown around for heart disease, cancer risk reduction, all these things, and uh, and often you don't see them tied into brain health, and you have to hear that conversation from somebody specifically from your type of specialty or one of the specialties around brain. And there's psychiatrists releasing studies and books about pharmaceutical not pharmaceutical, about nutritional psychiatry, and how some people will respond, I imagine, in combination with other therapies, really well to changes in their diet. And what we're talking about reducing always are the things that I think the conversation started, for me at least. I started to notice a lot more conversation around diet and the brain health, probably at the beginning of, say, 2013, 2014, somewhere there, where it really started to take off. And people were just talking about, reducing white, highly processed breads, cereals, and sugars. And that was my diet. I did basically that, what they said, reduce the amount of sodas I was drinking, decrease the amount of white bread I was eating with every single meal, um, uh, and stopped having cereal for breakfast. And my fatigue dramatically improved. I stopped having sugar in my coffee, uh, and and that and that made a massive difference. It was kind of the thing that I could do to support my body, and didn't have to outsource that onto my neurologists, my physical therapists, my cognitive therapists. I didn't have to do that as well. I could take that little responsibility, and I could control that really well. And I just feel like, as far as the science is concerned, there still seems to be a little bit of uh, a gap that needs to be made up by the medical industry about how to approach nutrition. And I understand there's more to it uh, than what I'm saying. There's more to it as to why that might be the case. A lot of the times that might be the case because, um, again, uh, physicians are just not skilled in that area. They're not educated in that way, so they can't advise something that they're not practiced in.
Yeah, I think you're right. And I think, the area of human nutrition is, it's a battle zone sometimes. I think, people are there are some what I would say entrenched camps, who have very strong feelings about one thing or the other. But where I think there does seem to be consensus, if you will, right, is that, you know, caloric values matter, and making sure that, you're adequately controlling your overall level of energy intake, right? And I think I don't know how it is in Australia. I know that here in the States, unfortunately, many people here are suffering from like energy toxicity, right? We're like
Mhm.
taking in too much and we need less, given what we're doing with that energy. So, the obesity epidemic is real, and it has very real consequences physiologically. And where I think things get a little more squirrely and difficult to discern where the truth is when you go kind of beyond where I've said, which is, okay, we have consensus, calories matter, you need adequate protein, you need adequate fiber and nutrients. Simple carbohydrates, probably not great for us in large amounts. Everything beyond that, it starts to get a little more difficult. But I think from a pragmatic perspective and an ease of use perspective for, frankly, just people in general, but
Mm.
definitely, patients. Focusing on those variables can go a long way in making things better. And the other part component of it that we haven't really touched on, right, is, and I think it's interesting, and maybe you're the person you're referencing that comes to nutrition from a kind of psychiatric perspective. I think it'll be a fascinating thing to do because ultimately our diet and our eating is human behavior, right? Which is a purview of our, our whole body and system. So we know we can alter how people feel about eating now with some of these GLP-1 inhibitor, medications. So it's,
Ozempic, for example.
yeah, and it's not, and I think the notion that um, eating and diet and nutrition are all matters of sort of choice and willpower and whatnot. I think it's dated. I think, and we know this in the neurological setting in terms of brain injury because we have people who you can have the right injury to the brain where people will not appropriately satiate and
Mm.
they will eat far beyond what they should and from a health perspective and also what they did before they had this brain injury. And there's a neuro term for it because we have to have words for things so we can sound smart, right? But this is hyperphagia. This is known. You can induce this if you damage someone's brain in the right way. So that tells us that this is not a matter of necessarily always decision making or
Yeah.
willpower. So if we have interventions that work, we need to use them. So the role of all of this is still evolving.
I love that you said that about the possibility that somebody could injure their brain in that particular place that changes the way that they experience satiation or not. Because I've met stroke survivors who do not get the signal to eat, who actually forget that they need to eat and they have formed a new habit and they eat when other people in their family eat. And as a result of that, they've lost, you know, two-thirds of their body weight. They were overweight and they had a stroke. And then as a result of that, they don't get the signal for hunger.
Well, they don't, there's that. There's also, I mean, it's very, very complicated to try
Yeah.
to unpack all of this, but, we also know that our 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 nervous system controls our gut too,
Mm.
and our gut has its own nervous system,
Hmm.
and that's what promotes motility in the gut and moves food along. And if it's moving relatively faster or slower out of your stomach, you're going to feel more or less full from that standpoint, and then you're going to impact absorption potentially of different things. And so it gets to be because exactly as you said, you can have people who in the wake of a neurological insult, they either don't satiate, so they just want to eat all the time, or they have difficulty with controlling their behavior from an inhibitory standpoint. And so they see food and they want to eat it. Or you can have the opposite, like you're saying, where maybe they have a really big problem just with initiation in general. So they don't initiate eating.
Hmm.
Or maybe their gut isn't quite working the way that it was before all of this happened for any of various and sundry reasons. And so they feel full all the time and they don't want to eat. Or, their food moves more slowly and they don't absorb as well. Or, the certain essential amino acids aren't getting absorbed. And there's a whole host of possibilities there that are complicated, and I don't pretend to understand them, nor do I think they are understood, but they're there to be explored. And for an individual who's going through that, I think at least understanding that it may be connected is a good starting place to try to approach things from a practical perspective.
Yeah. I really appreciate your insights into that. Uh, they're things certainly that I haven't thought about as well. And I don't begin to know the first thing about it. I just know what worked for me, which was just very simple changes. And they would probably work for anybody, regardless of whether they're experiencing a stroke or they've had a heart attack or cancer or whatever. It would just make life a little bit easier. Um, Diet was one of those things that I knew I wasn't doing well, that I could have improved, and then became necessary for me to improve after I became unwell. Um, as we wrap up, I just want to make sure that people who may want to reach out to you know where to go. Tell me the name of the organization, how people uh, come into your organization to work with your team, like what stage of their recovery perhaps does that happen, and yeah, just give me a little bit of
Sure.
insight into that.
Yeah, so again, our organization is called Center for Neuroskills. Center is actually spelled CENTRE. You can find us online, in your favorite search bar du jour, or you can throw in neuroskills.com and that'll bring you right to our page. Our page has a tremendous amount of information about things like what we've been talking about as well. So it's a great resource just for people in general who have experienced any kind of acquired brain injury, whether that's traumatic brain injury, stroke, or there are many other buckets. Um, we In terms of how people find their way to us, we really again fill that need between either hospital-based rehabilitation environments and home. That's kind of, in my mind, the ideal scenario is don't wait, and get home and realize 6 months down the line that you really would benefit from something like what we provide. Seek out services, whether it's with us or someone else, like us. And there are other organizations out there that do similar things. Take advantage of that, I guess, if you're especially if you're in the States, and it's an option for you. But if it's with us, great. And we can also help folks who have, maybe they've been at home after the hospital and they've realized, I need a little bit more than a couple hours a week of physio and OT and speech in that fragmented kind of environment that we described. So yeah, so there's contact information for how to reach out on the website. My, information and bio and all of that is on there. I am one tiny portion of a much larger thing, and I stand on the heels of everyone who built the organization before me and everyone who does it now. So I'm just a small part of it. I think it's much broader. In terms of people who might want to reach out and work with us, I mean, I'm totally biased. I think we have a great organization that the work that we do is so inherently gratifying that I think it's a great place to work. But people who come from any of the backgrounds I mentioned on the clinical side, whether that's um, medical, nursing, physical therapy, occupational therapy, speech, case management, social work backgrounds, counseling backgrounds, substance abuse backgrounds. We need people from all of that to help people. And then, of course, we also have a lot of administrative and other, kind of back of house people that really do great work for us too and help support the clinical mission by helping the business mission. So, yeah, people who are interested in working with us, please, there's contact information on there for, our various occupational avenues too. Did I cover everything you
I
asked,
think
Bill?
so, mate. I think so. You think you've done
Okay.
really well.
Yeah. The
Uh,
other thing I will say is for people who are recovering from stroke and suffering from stroke, I'm also, and as an organization, we're involved with American Heart Association. Lot of information about stroke in general that is written at a level for people to understand is available through the American Heart Association's websites, guidelines, et cetera. So that's another good resource for people to kind of start with.
We'll have all the links in the show notes anyway for people to find you guys and yourself. I really appreciate your time. Thank you so much for joining me and answering my questions.
Yeah, I appreciate being here. Thanks very much. And again, congrats on building such a great platform. It really is something special.
Well, that brings us to the end of this eye-opening episode with Dr. Matthew Ashley. His perspective as both a neurologist and legal advocate challenges the traditional concept of a recovery plateau, offering hope and practical strategies for stroke survivors who are determined to keep improving. Before we wrap up, I want to thank everyone who's part of this incredible recovery after stroke community. Your support through comments, ratings, and shares on YouTube, Spotify, and iTunes is what keeps this podcast going. If today's episode resonated with you, please consider leaving a 5-star rating or a like and a comment. It truly helps others discover the hope and inspiration found here. For more information on Dr. Ashley's work, please visit his website at neuroskills.com to learn more about his comprehensive approach to stroke recovery. And if you'd like to support the podcast, head over to patreon.com/recoveryafterstroke. Every contribution helps me bring more stories, resources, and hope to stroke survivors around the world. Thank you for listening today. I look forward to bringing you more inspiring stories and practical insights in the next episode. Until then, take care and remember, your recovery is possible, one step at a time.
Importantly, we present many podcasts designed to give you an insight and understanding into the experiences of other individuals. Opinions and treatment protocols discussed during any podcast are the individual's own experience, and we do not necessarily share the same opinion, nor do we recommend any treatment protocol discussed. All content on this website and any linked blog, podcast, or video material controlled this website or content is created and produced for informational purposes only and is largely based on the personal experience of Bill Gasiamis. The content is intended to complement your medical treatment and support healing. It is not intended to be a substitute for professional medical advice and should not be relied on as health advice. The information is general and may not be suitable for your personal injuries, circumstances, or health objectives. Do not use our content as a standalone resource to diagnose, treat, cure, or prevent any disease for therapeutic purposes or as a substitute for the advice of a health professional. Never delay seeking advice or disregard the advice of a medical professional, your doctor, or your rehabilitation program based on our content. If you have any questions or concerns about your health or medical condition, please seek guidance from a doctor or other medical professional. If you are experiencing a health emergency or think you might be, call 000 if in Australia, or your local emergency number immediately for emergency assistance, or go to the nearest hospital emergency department. Medical information changes constantly. While we aim to provide current, quality information in our content, we do not provide any guarantees and assume no legal liability or responsibility for the accuracy, currency, or completeness of the content. If you choose to rely on any information within our content, you do so solely at your own risk. We are careful with links we provide. However, third-party links from our website are followed at your own risk, and we are not responsible for any information you find there.